Thanks so much for that introduction, Corey. That was great. So, as you mentioned, I'm Andrea Sereda. I'm a safe supply prescriber, here over in London, Ontario. And like you said, we have one of, the longest running and largest safe supply programs here in Canada. So, our program across the country, programs look a little bit different. Ours is a very low barrier harm reduction program, and it's embedded within primary care. So all of the patients are my family practice patients. And the way that we practice safe supply is with a daily dispensed take-home dilaudid model that people use wherever home is for injection use. And we really think a lot of our outcomes are actually, our exceptional outcomes are related to, that combination of safer supply and the low barrier healthcare that we offer. So I was asked to comment pretty briefly on barriers to expanding delivery of safer supply in London. And really there's two main streams of barriers that we're facing right now. The first barrier is capacity, and I heard other panelists talk about this as well. We have about 300 folks on safer supply in London, but that's in a context of at least 5,000 injection drug users here in London, and we think it's certainly more in the past year. So again, even though we have one of the biggest programs in Canada, we're barely making a dent, right? We're really just a drop in the bucket of the need that's out there. So if we're going to actually bring safer supply to everyone who needs it and wants it, it's never going to be achieved through individual doctors' prescription pads. It shouldn't either, and that's a whole nother talk altogether. But if we're going to scale safer supply up, it needs to be a public health model. Government needs to legalize and regulate. Community compassion clubs need to be allowed to exist, and other, grassroots community models need to be allowed to start and then expand. So, again, in London, we know we can't solve this poisoning crisis on our own. So we're pivoting just a little bit in our work, and we're making research a bigger part of our approach, because we're trying to lay the evidence base, for the great outcomes from safe supply, from the safety of safer supply, and lay that evidence so that we can, push government to enact a wider public health approach. But government at all levels, then they need to actually decide to use that evidence that we're generating and really do the right thing for people who use drugs. Okay, so that's the first barrier, that's scope of need. And the other big barrier we're hitting up against more and more frequently are the drugs that we actually have available for safer supply. So when we started in London in 2016, and up until about the middle of 2019, we're using, hydromorphone, and we were actually able to fully divert the vast majority of our safer supply folks away from street supply just with hydromorphone. But what we started seeing, later 2019, and certainly through, the pandemic starting in March 2020, is this really huge increase in volume of use for people who are still using the street fentanyl supply. So we're still able to help, folks reduce their fentanyl consumption with hydromorphone, but the amount of people who are able to, quit and divert completely from street supply is certainly quite less. So to help those folks who are dependent on those higher volumes and higher concentrations, we need better drugs. We need to meet people where they're at. We need to be able to give them the drugs that they actually want. And that means we need a spectrum of drugs. Individuals aren't all the same, and their drugs aren't all the same. So we need liquid fentanyl, we need sublingual fentanyl and fentanyl tablets. We need heroin in all of its consumption forms that people can, again, still take home and use unsupervised in their own manner. Fentanyl is really wide. So pharmaceutical fentanyl, is widely available in hospital, but it's not available in community. And that's because of provincial regulations around what is on your different community drug formulations based on what province you're in. So provinces have the power to change this. It's really not that hard, but they need to, again, choose to do the right thing and choose to listen to the community of people who use drugs and those of us who care for them. So really, to summarize, we as a community really know what we need to do to bring real safer supply to everyone who needs it and wants it. It's not rocket science. The barriers to doing so are artificially created. They're created by our provincial and our federal governments, and those governments maintain those barriers through stigma and this false morality around certain types of drugs. So I'm really hopeful that, events like this and groups of people like this, that we can actually use our powerful voices. And I see a lot of powerful names and voices on the list of attendees today to really demand equity for all people who use drugs and really end this death crisis. Thank you.
Thank you so much, Andrea. Wonderful to hear from you and to hear the perspective of prescribers.